Welcome to the introductory webinar about the Perinatal Quality Collaborative in Pennsylvania, called the PA-PQC. I am Robert Ferguson, the Director of Government Grants and Policy for the Jewish Healthcare Foundation. And by the end of this afternoon's webinar, we hope you will be able to describe the PA-PQC's collective aims and the roles, including the timeline and the driver diagrams and the quality metrics that are associated with the PA-PQC. And importantly, we hope that you will be able to describe how to join the Pennsylvania PQC. After this initial overview that I will give, Dr. James Cook from Geisinger and the Northeastern Pennsylvania PQC will describe how the PA-PQC is affiliated with the regional Northeastern PA-PQC. And to help you and your team achieve the aims of the PA-PQC, the Vermont-Oxford Network, or VON, will be describing the neonatal abstinence syndrome training resources and toolkits and data feedback reports that will be available to the sites that join the PA-PQC. Lastly, an important part of the PA-PQC is using data to help drive continuous quality improvement. And we will be showing you visuals of an online data reporting and dashboard system that will allow PA-PQC sites to report the aggregate information for the PA-PQC measures and immediately see your site's progress over time and how that compares to sites in the PA-PQC, including your own. And at the end, we will answer any questions that you have throughout this virtual session. And to ask questions at any time, please use the chat panel and send your questions to all participants so that the panelists, including the participants, can see your questions. And we will first cover the definition and the structure of the PA-PQC. And this next slide shows that Pennsylvania became the 36th state in the U.S. To have a PQC available. PQCs are essentially networks of teams that identify processes that need to be improved and quickly adopt best practices to achieve the collective aims of the group. And this includes work across prenatal and labor and birth and the newborn and the postpartum services. PQCs typically use a method called learning collaboratives, where teams come together to learn how to implement key interventions to achieve common goals. They then return to their organization to adopt the key interventions and test ideas, measure whether these interventions have moved the needle towards the collective goals, and then reconvene at the next learning collaborative session to share what worked well and what didn't work well in order to inform the collective work of the group in a peer-to-peer learning format. Prior to the formation of the Pennsylvania PQC, the March of Dimes coordinated a PQC task force in Pennsylvania, which had a goal of creating and launching the Pennsylvania PQC. Building on this work, the Jewish Healthcare Foundation organized a statewide advisory group. And at that time, the advisory group set a focus for the PA-PQC on reducing maternal mortality and improving perinatal care for neonatal abstinence syndrome and opioid use disorders. The advisory group met in November and February, and it includes state agencies providers, health system associations, and provider associations, including health plans, community-based organizations, researchers, foundations, quality improvement collaboratives, and advocates as well. And following the first advisory group meeting in November, JHF helped to kick off a series of work groups that met through early March to create the driver diagrams and the quality measures for each of the 3 focus areas of the PA-PQC. Each work group was chaired by a leader whose name is depicted on this slide, and this leader had content expertise in each of these topic areas. And during this time, the advisory group oversaw the work of these work groups as well as the PA-PQC in general. Most of the work groups' work has concluded. However, the policy work group will be ongoing. And as an example, if the PA-PQC participants encounter policy barriers when they try to make improvements to their processes towards the collective aims, the policy group will help to analyze the policy issue and then make policy recommendations to help the PA-PQC sites. The policy group is also helping to expand perinatal bundled payment models in Pennsylvania in order to help adopt best practices for improving care. And to avoid reinventing the wheel, due to all the work that's been done elsewhere, the PA-PQC work groups began by assembling and aggregating all the best practices and resources from the other 35 PQCs in the U.S. This included documents from ACOG's Alliance for Innovation on Maternal Health, which is known as AIM. We also referenced a lot of the work that the Illinois PQC has done, including the Ohio PQC. And then finally, we used the toolkits for neonatal abstinence syndrome from the Vermont-Oxford network. And these work groups have then made revisions to the main outputs, including the driver diagrams and quality measures, to ensure that they fit the context of Pennsylvania, including the expertise within Pennsylvania. And the work groups, in the end, produced the quality improvement method for the PA-PQC, including the driver diagrams and the quality measures for the 3 foci of the PQC, being maternal mortality, opioid use disorders, and the neonatal abstinence syndrome. And throughout the process of launching the PA-PQC, there has been significant leadership from both neonatal and maternal physician champions across the Commonwealth. And over 140 people have collaborated across systems and across disciplines to help create the plan for the PA-PQC. The information that we will be presenting this afternoon is based on their work and contributions and ideas. We are currently in the phase of recruiting organizations to join the Pennsylvania PQC. And today's webinar is meant to give more information about the PA-PQC to interested organizations, and ultimately to help prepare these sites that will join the PA-PQC for the kickoff and the first learning collaborative on April 24th in Harrisburg. The Jewish Healthcare Foundation and its nonprofit operating arms, the Women's Health Activist Movement Global and the Pittsburgh Regional Health Initiative, are helping to stand up and administer the PA-PQC. As a neutral convener, JHF operates as a think, do, train, and give tank. And over 20 years, the JHF and PRHI have used quality improvement and patient safety methods in a range of healthcare settings. And JHF has also recently adopted the learning collaborative model for patient-centered medical homes in Pennsylvania, the Centers of Excellence for Opioid Use Disorders in Pennsylvania, as well as HIV and AIDS service organizations across the Commonwealth. And one of the Foundation's current priorities is around improving perinatal care to improve outcomes for a mom and baby dyad. And through the PA-PQC, as indicated on this slide, JHF is working with HapEvolve, which is a subsidiary of the Hospital and Healthcare System Association of Pennsylvania, to create the online data reporting and dashboard system that will be used in the PA-PQC. JHF is also working with the Healthcare Improvement Foundation in Eastern Pennsylvania, and the Healthcare Improvement Foundation will be providing additional assistance with facilitating the Pennsylvania PQC learning collaborative sessions and providing quality improvement support to the PA-PQC teams. JHF is also working with the Vermont-Oxford network to allow the PA-PQC sites to access the neonatal abstinence syndrome training program and toolkit that Vaughn has developed. The PA-PQC is working closely with committees at the state. Specifically, the PQC is serving as an action arm of the Pennsylvania Maternal Mortality Review Committee, a group that has an acronym of the MMRC. The MMRC is essentially identifying the causes of maternal deaths and then issuing guidelines and recommendations to help reduce maternal mortality. And the Pennsylvania PQC will help spread and implement those recommendations across the participating sites in Pennsylvania. The PQC is also working with the multidisciplinary work group on infants with substance exposure, which is called Midwise. And for example, the PA-PQC will be helping to disseminate the midwives' interagency protocols for plans of safe care for children who are born affected by substance or with withdrawal syndromes. And as I previously noted, the PA-PQC is focused on improving the outcomes of both the mom and baby as a dyad. And this next section of the presentation will be covering the specific goals of the PA-PQC within this focus. One goal is to decrease maternal mortality and severe morbidity across the races, ethnicities, and the regions in the Commonwealth. And a set of other goals relates to opioid use disorders. The PA-PQC will be helping to improve substance use disorder screening, opioid use disorder diagnoses, and referrals to treatment among pregnant women. And another goal is not only to refer, but also to help initiate treatment as it relates to medication-assisted treatment. And we also want to increase the duration of that care. And related to that, the PA-PQC also has a goal to increase engagement in the prenatal and the postpartum care for this population. As it relates to the PA-PQC's focus on opioid-exposed newborns. The PA-PQC will be helping to support quality improvement work that relates to increasing the reliability of screening for opioid-exposed newborns, including neonatal abstinence syndrome, and increasing the use of non-pharmacological treatment for opioid-exposed newborns, as well as increasing rooming in with families during the hospital stay for opioid-exposed newborns, and ultimately decreasing hospital length of stay for newborns with a neonatal abstinence syndrome. And there are also goals around increasing breastfeeding and well-child visits among newborns with neonatal abstinence syndrome. And the next part of this presentation relates to the PA-PQC's current focus on recruiting perinatal sites in Pennsylvania. And by April 1st, we have a goal to recruit at least 30 sites to join the Pennsylvania PQC. Initially, the PA-PQC is focusing on high-volume labor and delivery sites with a level 3 or 4 NICUs. Throughout 2019, we hope to recruit all of the labor and delivery sites and the NICUs in Pennsylvania. And these sites and the providers will need help from stakeholders and community organizations to achieve the collective aims of the PA-PQC. With this in mind, the PA-PQC is also engaging health plans and other perinatal teams, including pediatricians, county health or human service agencies and departments, as well as the Centers of Excellence for Opioid Use Disorders and the PACMAT programs, as well as other community-based organizations such as the Healthy Start organizations in Pennsylvania. And the next section of this overview goes into some of the roles of the provider organizations and the health plans that will join the PA-PQC. The multidisciplinary team that joins the PA-PQC as a provider site will essentially participate in the face-to-face learning collaborative sessions that will be held on a quarterly basis. They will also help to launch plan, do, study, act quality improvement cycles in between these sessions, and attend virtual sessions in between to help support and inform their quality improvement projects. They will also be able to access the Vermont-Oxford Network's Universal Training Program and to participate in the Von Day quality audits to help their organization become a center of excellence for education and training for infants and families impacted by a neonatal abstinence syndrome. And finally, the participating sites will also be asked to aggregate their own data and report that aggregate information through an online data portal and a dashboard that is developed by HAP Evolve. And the team that joins the PA-PQC as a health plan will do similar activities, including participating in the learning collaborative sessions and the virtual sessions, as well as engage their related contracted resources and care management teams in the PA-PQC activities to assist the teams in their network on quality improvement projects. And also, we will be asking the participating health plans to help give feedback to the PAPQC sites on metrics that require claims data, such as the metrics around postpartum care visits, as well as a child care visits. And ultimately, the PAPQC is here to help these sites adopt best practices and to formalize quality improvement methods for reducing mortality and improving perinatal care for women with opioid use disorders and opioid-exposed newborns. There are a lot of other benefits that are listed on this slide, but these benefits all stem from this core aspect of the PAPQC. And to become a PAPQC site, the first step is to complete an online registration form for provider organizations and health plans. This form essentially asks you to identify a team within your organization to help lead the PAPQC activities that I just summarized. That team can then register for the PAPQC's learning collaborative sessions that will be held on the dates indicated on this slide. All of the registration steps are accessible through one link, which is displayed on your slide, and it is the Get Involved page of the PAPQC website. And for provider organizations, the registration form that I mentioned essentially asks you to identify the provider champions for the neonatal and pediatric and as well as the maternal health work of the PAPQC. These champions play key roles in leading quality improvement projects in organizations and helping to gain the buy-in of their colleagues. There is also a team role around the administrative champion. This champion can give a project management assistance for the quality improvement projects and learning activities. The administrative champion can also help coordinate the efforts to complete agreements, whether it's a business associates agreements or the VON participation agreements. And they can also help to coordinate work to complete a few PAPQC surveys that will be administered to help gain an understanding of the existing processes you as a team have around the three foci of the PQC. And the team at the Jewish Healthcare Foundation will contact this administrative champion to help complete these agreements and better understand the strengths and needs of your team through those surveys that I mentioned. In terms of the other team roles, there is also a role around data collection and reporting. And the person who fulfills this role of the team can help collect, aggregate, and report data for the PAPQC measures through the online data reporting and dashboard system that I mentioned. This individual can also assist with the VON Day quality audits that you will hear more about in a bit. And they can also help to gather complete medical records when requested by the Pennsylvania Department of Health, as it relates to the Department of Health's work to review cases of maternal deaths. In terms of the team role for quality improvement and learning activities, this includes different people who will be on your team to help with quality improvement and to participate in the quality improvement projects and the learning collaboratives, as well as accessing the neonatal abstinence syndrome training program from the Vermont Oxford network. And also there is an opportunity to identify community-based organizations outside of your health system that you would like to engage in your PAA-PQC quality improvement work. And as I noted, there is also a form for health plans to join the PAA-PQC. We will be asking health plans to identify team members to participate in the learning collaboratives and to engage their care management teams to work with the PAA-PQC providers as it relates to their quality improvement efforts, and as previously noted, to give a feedback on measures that may require claims data. And similar to the provider organizations, the health plans can also recommend community-based organizations that they think should be engaged in the PAA-PQC work. The next section of the overview covers the major activities of the PAA-PQC to help you further think about how to best structure your PAA-PQC teams to accomplish the collective goals of the collaborative. And the first step, which is identified on this slide and was just covered, involves identifying your core PAA-PQC team. And we expect that by March 2020, each team from an organization that joins the PAA-PQC will conduct quality improvement projects on the three foci of the PAA-PQC. However, this does not need to be done all at once. In other words, each team can figure out how to best prioritize and phase in the quality improvement projects for the three foci of the PAA-PQC. And then the next step involves collecting, aggregating, and reporting the aggregate information through that online data portal. There are a set of required metrics across the three foci that all sites will be asked to collect data around and to report that aggregate information through the online system. There are also a set of optional quality measures that you can use as it relates to your specific quality improvement projects. The PAA-PQC will phase in certain optional measures over time to help focus the collective work of the group. And we will be covering these specific measures in a bit. The PAA-PQC includes data reporting mainly just to help drive quality improvement projects and to tailor the content of the of the learning collaborative sessions so that it is relevant to you, and it's also meant to help you learn from your peers. For example, if one group is consistently screening 95% of pregnant women for substance misuse, we want to help uncover how they are doing that so that we can spread those best practices to other sites in the PA-PQC. And the next series of slides show a timeline of these activities. After the first learning collaborative on April 24th, we will ask the PA-PQC sites to report the aggregate baseline data beginning in the month of May for the required metrics, as well as the optional metrics that pertain to your team's quality improvement work. And also in May, the PA-PQC teams will begin to launch their quality improvement projects for a goal that their team is focused on. And to inform this work, there will be a second session on June 28th in Harrisburg. And throughout this time, the sites will be able to attend topic-specific virtual sessions where they will learn more information about how to implement a particular key intervention and to share what's working well in terms of their quality improvement projects to help inform the collective work of their group. They will also have access to all the resources that are available through the online portals and the websites. And during the next 3 months, meaning July through September, the PA-PQC sites will be conducting their quality improvement projects, and these sites will also have the option of reporting their monthly results at the beginning of each month. However, at the least, the intent is to ensure that each site reports data during a month that precedes the face-to-face learning collaborative sessions. The intent is that this will help ignite another round of quality improvement cycles before the fourth learning collaborative session of the year on December 11th. And the timeline for the year of 2020 will be provided at a later date. And to offer additional feedback on your site's neonatal abstinence syndrome results and outcomes, the Von Day quality audits will be conducted between July 8th and 12th, which is going to be the baseline period, and then again in July 2021, in order to help measure the impact of your work. The Von team will describe this in greater detail in a bit. This sequence of events includes learning collaborative sessions on April 24th, June 28th, September 24th, and December 11th. These sessions will give an opportunity to your team to report out on what is working well and what is not working well, and also to learn how your peers in Pennsylvania, as well as other content experts, have implemented the key interventions for one of the goals of the PA-PQC. And importantly, these learning collaborative sessions are meant to help jumpstart your quality improvement work that will occur in between each session. And the overall intent is that your team will walk away from each session with ideas for how to begin your quality improvement cycles around improving care for opioid use disorders and opioid-exposed newborns, as well as reducing maternal mortality once your team returns to your organization. And just to give you an example of what each of these sessions will look like, this screen shows the agenda for the morning of the April 24th session. And one of the main objectives during this introductory kickoff is to help understand how to prioritize and to design your team's quality improvement projects so that you can start to launch this work within your organization beginning in May. And if for example, your team may decide to begin a quality improvement project on a prenatal substance misuse screening, and the idea is to consider the collective goals of the PA-PQC, including the three foci of the PA-PQC, but then to prioritize within your own team where you want to begin based on your organization's context and improvement opportunities, which will vary across organizations and teams. And to help your team think about how to implement key interventions for quality improvement projects, the afternoon of April 24th will include knowledge cafes that will be led by your peers around certain topics, including neonatal abstinence syndrome screening, non-pharmacological treatment protocols for neonatal abstinence syndrome and substance misuse screening, as well as staff and patient education for substance use disorders. And there will also be a knowledge cafe around the protocols for hemorrhage and severe hypertension, as well as the fourth trimester based on ACOG's updated guidance and protocols. There will also be time for your team to huddle and synthesize this information so that you leave the session with some tentative ideas and plans for how to begin your quality improvement projects once you go back to your organization. And the next section covers the PA-PQC's driver diagrams and quality measures for each focus of the PA-PQC. And before we go into that, I wanted to take a moment to define what a driver diagram is. So these diagrams typically include three main parts. They begin with an aim in terms of what you want to achieve and SMART objectives that can be used to ensure that the aim is measurable and actionable. And then for each aim, you then think about the structures, processes, and the systems and the norms that need to be impacted in order to achieve that particular aim. These are called the primary drivers. And for each main driver, you then identify specific actions that you want to attest. And these actions are typically called key interventions. And lastly, measures can then be designed for the primary drivers as well as the key interventions to help monitor whether they have been implemented and whether they are actually impacting the goals and SMART objectives that your diagram is meant to impact. This next slide summarizes the driver diagram and quality measures for the PA-PQC's focus on maternal mortality. The main drivers include recognition and response to disparities, and also comprehensive assessments, including connections to appropriate follow-up services. And there are also categories around expanded postpartum care as it relates to the ACOG fourth trimester. And then, as you can see on the slide, the groups have also identified important categories around reviewing maternal and morbidity cases and standardizing protocols for hemorrhage and severe hypertension, among other important categories. And then I would also like to note that the required metric for this topic is severe maternal morbidity. And initially, the PA-PQC will be focusing the collaborative on content as it relates to the ACOG fourth trimester, as well as protocols for hypertension and hemorrhage. The full version of the driver diagram that includes the key interventions as well as the specifications for each measure can be downloaded and accessed through the PA-PQC's website. And we will make sure that you have those links to access this information. This next slide summarizes the driver diagram and quality measures for opioid use disorders. The primary drivers include patient and staff education, screening for substance use disorders and comorbidities, and linking patients to appropriate services, including medication-assisted treatment. And then in terms of the required metrics, these include screening for substance use disorders and opioid use disorder diagnosis rates and initiation in a medication-assisted treatment, as well as the duration and continuity of that care. And then finally, there is a required metric around the percentage of women with opioid use disorders who are receiving a timely postpartum visits. And the main driver diagram, including the definition for these measures, can be accessed online too. And this next slide summarizes the driver diagram and quality metrics for neonatal abstinence syndrome. And the primary drivers include standardizing screening and ensuring that there are standardized protocols for pharmacological treatment, as well as non-pharmacological measures. And in terms of the required metric, it includes the hospital length of stay for newborns with neonatal abstinence syndrome. And And we recognize that this will require some support for data collection. And as a result, we are including an opportunity for the PA-PQC sites to receive some stipends and a patient safety award to help offset the cost of data collection. And to this opportunity, as it relates to the stipends and awards, is within the context of a patient safety fellowship program. And in 2019, the Jewish Healthcare Foundation is focusing our patient safety fellowship on comprehensive pregnancy experiences. And the fellows, meaning multidisciplinary graduate students and young health professionals, will learn patient safety methods within the fellowship, which runs from early June through the month of July. And through this fellowship, the PA-PQC sites will be eligible to receive certain amounts to help offset data collection costs. Those sites that join the PA-PQC and the fellowship will receive $1,000 for each team that also is able to report baseline data for the PA-PQC. The application to join the fellowship will be due around April 30th, and it will be online within about a week or two. There is also $3,000 available for each site for up to 5 sites that are selected to participate in the fellowship. And the sites that participate in the fellowship will be a nominee for a patient safety award that will be in the amount of $20,000 that will be awarded to one site in the month of July. And the sites that are selected to participate in the patient safety fellowship and awards will be selected based on the comprehensiveness of the team's processes for identifying and responding to a comprehensive set of issues, including substance use disorders, hypertension, depression, and social determinants of health, and also the feasibility of replicating that process to other PA-PQC sites. This slide indicates the roles of the sites that participate in the fellowship, and essentially it involves presenting to the fellows and allowing the fellows to interview your team to help understand how your organization is wired for excellence in perinatal care. And then the site that will receive the patient safety award, that $20,000 amount will be awarded based on a similar set of criteria, which will be explained in further detail once the online application is available. So with that overview of the PA-PQC, I am pleased to introduce Dr. Jim Cook, who is the Executive Director and Neonatal Lead for the Northeastern Pennsylvania PQC. And he will be giving an overview of this regional Northeastern Pennsylvania PQC.
Thank you, Robert. And thanks for everybody for joining. I just wanted to talk a little bit about our regional effort that's operating in collaboration with the State Perinatal Quality Collaborative. So just to give some background information, so the Northeastern Pennsylvania Perinatal Quality Collaborative developed in concurrence with the state effort. The Northeastern Collaborative is composed of these 16 counties. And for those who may not be familiar, this is a mostly rural part of the state. There are 15 delivery hospitals in this area, ranging from delivery services of a few hundred to delivery services in excess of a couple thousand births per year. And there are, of the 15 delivery hospitals, many of them are already part of a larger network. We also are interacting and hopefully being supported by the 3 MA insurers in our region. So this, just a little bit more background, if I can get this going. So this is a privately funded initiative that actually arose out of the similar ideas as the state collaborative, which was to get a collaborative effort started dealing with the problem we were facing with opioid use disorder during pregnancy, as well as the resulting neonatal abstinence syndromes in those babies. So a proposal, I proposed a draft and was fortunate enough for it to be funded through the Geisinger Health Plan, Geisinger Clinic Quality Fund, actually focusing on improving the identification and treatment of moms with OUD, as well as the standardized treatment and follow-up plans for infants with NAS. So we wanted to do this by establishing a regional perinatal collaborative, and that would imply that we would be sharing information amongst health plans and amongst health systems in our area that actually may be competitors. And that was a novel part of this proposal. So this timeline was that we started this effort in August of this year. By the time we hired folks, it wound up being August of 2018. And then we've been working internally within the Geisinger system to answer a few questions such as, what is the incidence of opioid use disorder in pregnancy in our populations? And how accurate is this diagnosis? So for instance, we're looking at of the patients who suffered from NAS, what % of those moms actually had a diagnosis of opioid use disorder in their charts? And we were surprised by some of our answers. We're also looking at our referral success. So for moms with that diagnosis, we're looking at the referral percentage to treatment and how long they stay in it. And we're also looking at the incidence of and the rates of prenatal appointment attendance for moms with opioid use disorder, as well as the rate of attendance of infants to their well child checks in their first year. So those are some of the outcomes that we're following. We've already done a lot of this research in our own data mining. We are aware of some of the obstacles in finding out this information, and we are here actually now collaborating with the state effort to help hospitals in our region through this process and to help them, hopefully encourage them to participate in the state collaborative. So we've started in the past few weeks actually trying to contact individual hospitals and providers in our area to encourage them to sign up for the state prenatal collaborative. For those who are already on this phone call, we kind of haven't talked to you yet because we already knew you were on the phone call. So we are in the process of trying to get a hold of those folks who are not on this phone call. This slide just lists our members, our leaders, and there's other folks who are helping us. We have some data collectors and data folks that are working with us, as well as some quality folks that are not on the slide who are also helping with our project internally. So I'm a neonatologist. I've been with the Geisinger for almost 30 years, and I'm leading this effort. But the person who's really doing all the work is Karina, who's in my office presently, and she's full-time project manager for this effort. So I am the neonatal lead. Gary Stoner is an expert in opioid use disorder during pregnancy. Danya McCain is a maternal fetal medicine specialist based in Wilkes-Barre, and Mary Weaver runs our opioid treatment clinics and oversees a lot of the referrals that go to the MATs. Next slide. A little tricky. So I want to just emphasize to folks that we are working with the state, a collaborative. We evolved kind of in a parallel track, but we have merged our efforts to try to get the state collaborative off the ground. We have similar goals and objectives. We are part of the state collaborative, so folks who join the state collaborative will automatically be part of the Northeastern effort. And we're here to help specifically those hospitals and providers in our region to succeed in the state project. So again, our focus, we don't have a focus on the maternal mortality and morbidities. That's really a statewide effort, but we certainly are focusing on identifying OUD in pregnancy and follow-up of neonates with NAS. I know that when we looked at our data, one of our most opportune issues was to use a better screening tool to identify opioid or even substance use disorder during pregnancy. And so one of our internal efforts within the Geisinger system is going to be to implement a better screening tool than we're already using now within our electronic medical record. So with that, I'd be open to any questions that are at the end of the presentation, so we can move on and stay on time. And it looks like we're going to be talking about Vermont-Oxford next stop.
Yes, so thank you very much, Dr. Cook. And as you indicated, please feel free to submit questions to all participants at any time, and then we will be sure to answer them at the end of this session. Well, to help give a more in-depth overview of the resources that will be available to the PA-PQC sites through the Vermont-Oxford network, I am pleased to introduce Dr. Roger Spohl, who is the president of Avon and his team, which will be giving additional background on the tools and the resources that will be available to you as a PA-PQC site.
Thank you very much, Robert. We here at Vaughan are thrilled to be joining the PA-PQC in these efforts. We believe that these state efforts are probably the most powerful tool towards collaborative learning and quality improvement that we have seen. Your teams will come together, do a lot of learning. You'll have excellent tools for measurement, both using our Vaughan Day audits as well as your own local measurement initiatives. You will structure PDSA cycles to test the potentially better practices that you will learn about from the NAS lessons. And you will have opportunities to share and learn from each other. Our ultimate goal is not just to make changes, but to make measurable improvement. In terms of what we're tackling, there is no question that the opioid issue is truly an epidemic and an emergency for the United States. This is data from the first part of the 21st century showing a 5- to 6-fold increase in the incidence of neonatal abstinence syndrome throughout the U.S. We here in New England are probably the second most affected region regarding this NAS epidemic, but you in Pennsylvania are not far behind. Clearly, in the more recent years, we have seen in Pennsylvania, as we've seen throughout the United States, further increases in the incidence of NAS, so much so that we have at least 10-fold increase overall in the incidence of NAS and a 5-fold increase in the resources used regarding hospital length of stay. So, where do we begin? We know that there have been authoritative guidelines published, but it takes a while for those babies to benefit from those guidelines. There's always a lag between when we know what potentially better practices exist and when they're widely adopted. Today, we're going to talk about collaboration and universal training. You're familiar with this idea of universal training because you do the NRP courses. Until we all got the same book, got the same manual, did the same training about how to approach babies who needed resuscitation in the delivery room, we had very variable results. Once an authoritative group, the Academy of Pediatrics and ILCOR, came out with an idea of universal training where everyone trains for a predictable event and improved outcomes. So, we're really testing this proposition around the ideas of NASS. Our first aim is to engage centers like yours in a multi-center QI collaborative focused on improving the quality, safety, and value of care for substance-exposed infants and their families. And secondarily, we'll promote the rapid cycle adoption of the AAP-NAS guidelines into clinical practice by standardizing NASS-relevant policies and practices. Can this be successful? We believe so. We believe that multiple groups have gotten together like yours and made huge impacts regarding neonatal care for abstinence syndrome. An example of this comes from our publication from an eclectic group of centers that participated in an internet quality collaborative regarding NASS. And here, just to take a look at a diverse number of policies and practices, ranging from the maternal care and substance use screening, to the evaluation of substance-exposed infants, to standardizing scoring, to using both non-pharmacologic and pharmacologic treatment, and supporting families and their infants to improve breastfeeding, we can see in all of these parameters significant improvements in care at the participating centers. And so I truly wish you well and look forward to working with you in the future on this project. And to talk a little bit about the nuts and bolts of the types of support that Vaughn will be offering, I'd like to introduce John McGregor, who's in charge of our learning systems management systems.
Hi, thank you, Roger. My name is John McGregor. I manage the Vermont-Oxford Learning System, which will be giving a much more comprehensive webinar about the steps that everyone will need to log in, get the users enrolled, and then exactly what that navigation will look like to access the lessons as we get closer to launch. But I definitely wanted to give you a little bit of an overview of what we'll be providing and some of the things we'll need to do or you'll need to do to get ready. One of the roles that Robert had mentioned before is the Vaughn champion or the administrative champion, which really has three key responsibilities. They're the point person at each center where they'll identify users to be enrolled, as well as becoming a super user on the LMS, looking at each one of the lessons, becoming familiar with the content, maybe identifying a lesson or two that they know could really benefit their center and their center's culture. And by doing that, they'll keep users motivated and engaged and hopefully working with our potentially better practices and the content and the lessons to really adapt that in your day-to-day work. Now, we know that some centers in Pennsylvania are already a Vaughn center, but for the centers who aren't Vaughn centers, the PA-PQC Administrative Champion will take on the roles of the Administrative Champion at the center to enroll all the users. And again, once we get closer, we'll have a really comprehensive webinar that talks about how you'll need to register users. And also, the centers who are non-Vaughn centers will have to submit a Vaughn participation agreement, and we can provide all the details and information if you have additional questions on that as well. This is just a quick shot of the online learning system that we have. There's 18 NAS lessons, so there'll be a list of lessons here that you can click on any one of those. Just looking back at the slide that Robert had presented earlier on the PA-PQC aims for opioid-exposed newborns, pretty much all of the content that we have aligns to those aims, from trauma-informed care, standardization, non-pharmacological strategies, to scoring, engaging families in feeding and nutritional support, as well as our virtual video visits that really go into depth with the mothers and their voices and their stories around a particular center in Vancouver in a very densely populated area with NAS. In addition to the actual lessons as well, there'll be abstracts and guidelines focused on NAS resources, policies, and also thinking about one of the slides that Robert mentioned about the driver diagrams. We do also have a host of quality improvement resources with videos, with experts reviewing exactly what a driver diagram is, what a SMART aim is, tons of different resources that you can use. And I will send Robert, that will distribute to everyone, a catalog with the list and a little bit more details of each one of the lessons so you can get an overview of some of the content that users will be looking at. And in addition to the lessons, we do have the NAS toolkit that we have, which is just an incredible document. Again, we would suggest that all the champions become familiar. We lay out the 8 potentially better practices that we do have that really the audit and the lessons are built around. So, for example, potentially better practice 1 is to develop and implement a standardized process for identification, evaluation, and treatment and discharge of infants with NAS. Potentially better practice 2 is to develop and implement a standardized process for measuring and reporting rates of NAS and drug exposure. So for potentially better practice 2, the Vaughn Day audit will help, but you'll also need to use your local state data to plot the dot, really to understand what's happening day to day with NAS at your center and culture. In addition, just to go over a couple more of these potentially better practices, again, number 3 is to create a culture of compassion, understanding, and healing for the mother-infant dyad affected by the problem of NAS. And potentially better practice 4 is to provide care for infants and families, insights that promote parental engagement in care and avoid separation of mothers and infants. And again, we're not going to go into all of the potentially better practices, but I just wanted to give you a sense that your work will be organized really around some of these principles, and you'll be measuring your progress first by testing and then adopting and adapting these potentially better practices over time. And I just got an email from our collaborative in Maryland who indicated that they've done just that. They finished a year's worth of work within the NAS online program, and each lesson generates a certificate for medical or nursing credit, and they've completed over 40,000 lessons and generated certificates and have made significant improvement, and they said, by adapting these potentially better practices in the work and data that they had from the audit. So just a lot of great gains that can be made with the content and the education that we provide. A couple of the lessons, we have 5 different chapters I mentioned of the virtual video visit that we went to a downtown East Side Center and hospital in Vancouver, and they had 2 different centers called Chiwei and Fur Families in Recovery, where mothers and babies room in together and where they really foster healthy pregnancies and positive parenting. And throughout the lessons, there's 5 chapters integrated within our other content where you'll hear these mothers' voices from Chiwei and Fur that really tell the mother's story and present a unique model of care that's actually spreading across the United States. And we also have what we call our facilitator's guide for those particular lessons within our other lessons, and it really outlines the table of contents and just an overview here. But again, we would encourage the champion to really review the table of contents because this acts as kind of a way that you can integrate these lessons in teamwork and create your own lesson plans and curriculums at your center within each one of these chapters of the virtual video visit. Also, I know that we had mentioned, too, about centers who are participating and working with the universal training to gain what's called the Center of Excellence status. Just to review that, it's very simple. I know that we talked about the core multidisciplinary team that you'll have. Now, you're able to enroll as many people as you'd like into the NAS universal training as you'd like at your center. We really want to make sure that we maximize the benefit for everybody that you have. But when you are submitting users on the enrollment spreadsheet to our LMS registrar, there'll be a column where you can mark who you want to be as your core team. And we will track those users, and once all of those users at your core team at your center complete all of the 18 NAS lessons, that center in your state will be designated as a center of excellence. And once 85% of all of those core teams at all of the centers are complete the lessons, the state of Pennsylvania will become a state of excellence, which just happened in Maryland. They launched with about 33 states, about 4,000 users, and they achieved the 85% goal in early December last year. And I just wanted, so that's really an overview of the learning system. Again, we are going to have a more comprehensive webinar training that goes really into the nuts and bolts about how everybody will log on, where they'll need to go to access the lessons and the resources, as well as enrollment and any other questions as we get closer to launch. But I just wanted to turn the presentation now over to my colleague, Courtney Scott, who will be talking to you a little bit about the Vendée audit.
Hello, everyone. This is Courtney Scott, and I am the Vendée's audit coordinator that will be working with you. So I just wanted to bring to your attention there will be 2 audits, one at the beginning and one at the end of the universal training. The inclusion criteria is infants treated pharmacologically for NAS at 7 days of age or less and discharged within the specified 3-month eligibility period. The audit will include up to 30 infants, and the eligibility details can be found in the Manual of Operations, which we'll go over closer to the time of the audit. I just wanted to let you all know that the IRB approval is extremely important. The primary purpose of this audit is quality improvement. But since the auditor will have access to protected health information, and since the results will be aggregated and possibly published, consult with your local institutional review board to determine what reviews and approvals are required prior to your participation. So within the audit, there are 2 parts, the unit and the patient level data. The unit level data consists of policy and guidelines for screening of maternal substance abuse, comprehensive treatment of infants with NAS, scoring tools, and so forth. The patient level data consists of information such as birth weight, gestational age, inborn versus outborn status, and those other items listed below. And these measures are reported to the centers. The total number of infants pharmacologically treated for NAS within the first 7 days of life, the total NICU length of stay, total hospital length of stay, total duration of pharmacological treatment, potential discharge delays, or the number of days after treatment stopped before discharge, percentage of children on mother's milk at discharge, medications used for treatment, and medications at discharge. The 3-month eligibility period will be determined by your team. You'll be using paper forms to enter your results. However, those paper forms will be retained at your center, and all information will be electronically entered into our system. A proposed eligibility period would be April 1st through June 30th. However, that is could be determined by your local team, but the audit window is July 8th through July 12th. If you have any problems with Vendée registration or data definitions and technical issues, please contact me at vondays@vtoxford.org or the number below. You can also send me any other questions.
Courtney, this is Roger. Just a quick point on your focus on IRB. Our IRB here has determined it is not human subjects research, but I think the important issue is that you talk to your local IRB about their determination. It may or may not need their formal approval. Most centers actually have gotten a similar determination, but we strongly advise that you talk, we know you need to talk to each of your IRBs about the status of this work, and we do have some materials available that Courtney can steer you towards sending your local IRB what we consider the status, the questions that need to be asked, and the support that we give.
Thank you. So the sooner we can get information on the data collectors, the sooner I can get that IRB information out to you, which I will leave in Robert's very capable hands.
Thank you.
Thank you very much.
Yep, and I just wanted to put our contact information up here if you have any questions, and then just turn it back to you, Robert.
Thank you, John, and the Avon team for that overview. And the final part of this overview relates to the PA-PQC's online data portal and the dashboard system. As noted, the intent of this data portal is to help the sites automatically trend the results over time and compare those results to the performance of your peers with the intent of driving peer-to-peer learning as well as quality improvement. And to help visualize what the system will look like, I am pleased to introduce Peter Gwen, who is the lead data analyst for quality initiatives at HAP.
So on the slide deck that everybody sees, this is just a mock-up of what the data portal would look like for everybody participating in this program. We're able to leverage many years, about 3.5 years worth of hen and hin experience developing a system to be able to have hospitals self-report data as well as be able to visualize data as well as part of a CMS program. So here, we try to keep it as simple as possible. In this example, and again, these are just mock-ups, but in this example, we're simply asking for a numerator-denominator pairings for the various metrics that you will be following. Moving forward, as Robert had suggested, there will be peer-to-peer segmentations and aggregations that you can compare against. So in this mock-up, you can see Hospital A, you can kind of see how the entire PQC aggregate is performing, as well as specific regions, and there can be different segmentations that you might be interested in comparing yourselves to. This is another an example of what a dashboard might look like. Again, this is just highlighting examples of, in this case, the percentage of women screened for an SUD. In regards to developing more full-fledged dashboards, those are just simple mock-ups. We have experience for several years developing dashboards, so this is a little bit more robust dashboard. I realize this is talking about sepsis, but as you can see, we use this as an illustration of what can be done using and leveraging Tableau. Here you can kind of get a sense of the different comparisons and segmentations you might be able to do, as well as a general layout that you might be expected to see. We are also aware of the need for an executive dashboard to be able to have just a high-level view, as well as being able to drive down into a deeper dive where comparisons might be a little bit more useful. So the idea here is to essentially allow everybody to have proper segmentations to be able to drive those outcomes that everybody's looking for to increase increase participation in terms of the self-reporting. Again, we're not asking for patient-level data, so it's just aggregates, as I mentioned earlier. With that being said, I'll turn it back to Robert. Thank you.
Thank you very much, Peter. And at this time, we will be answering any questions that you have. So as a reminder, to ask questions, please be sure that your chat panel is open. And once it is open, please send any questions to all participants. The other way to ask questions is over the phone, but in order to be unmuted, please click the raise hand button, which is in the participants panel. Once you click the raise hand button, I will unmute you so that you can ask your question or give a comment over the telephone. And just to help begin the discussions about the question and answers, we displayed some questions that we have received. And the one question is about the participants who may have been engaged in the PA-PQC work groups and advisory groups. And the question that's often asked is, in that case, does that person still need to submit the registration forms to join the PA-PQC as a participating site? And the answer to that question is a yes. We are asking all PA-PQC sites, including labor and delivery sites and the NICUs and birth centers, to officially join the PA-PQC by completing that online registration form. We want to make sure that you have a team that's in place that can actually do the quality improvement work with you. And the question that we have received in the chat is, will the slides be available for download? Yes, the slides, including the deriver diagrams and the definitions of all of the quality measures, are now available for people to download through the PQC website. I will be sure to show you how to actually do that before we end today's virtual introductory session. And another question is about how the recruitment targets of the PQC are focused on the labor and delivery facilities and the NICUs. However, some of the metrics relate to care in the community across the prenatal and the postpartum phases. And as a result, the question is often, how can our team within the delivery unit impact these measures that might be outside of our control? And in part, this is why we are encouraging people to go through that online registration process to identify your team. And I would suggest to make sure that you have a prenatal team members as well as a postpartum team members who can all be working together as one team to improve these sets of quality measures. And related to that, a question is about whether these independent clinics and practices that operate in the community should be registering on their own, or if they should be registering in partnership with a hospital or with a birth center. And I would suggest to register in partnership with that hospital so that you sign up as one team. However, if you do sign up on your own, that's fine. We can help coordinate the different registration forms that get submitted to us. And another question that we received is, should we fill out the registration form for provider organizations as a health system or at the hospital and site level? And I would say that in part this probably depends on how your health system or how your hospital is structured, meaning does quality improvement mainly happen at the system level, or is it at the hospital and site level? And we've seen examples where a coordinator at the health system level is coordinating efforts across all of the hospitals and sites within that system to join the PQC. And we've also seen individual hospitals sign up on their own. And both processes are fine, and if we get multiple applications from the same system or the same organization, we will be following up with those teams just to let them know that they have a larger team than anticipated. And then a question is, once you submit the online form, how can you make changes to your multidisciplinary QI team? You can make changes by contacting us at the PAPQC@whamglobal.org email address that I have on the very last slide of this slide deck. And a few other questions are displayed on the slide. One is, if I am a stakeholder organization, how can I join the PAPQC, since there's only a forum for health plans and the provider organizations? And as we noted throughout the presentation, the health plans and the provider organizations have an opportunity to identify community-based organizations and other stakeholders that they would like to join as part of the PA-PQC work. That's one way of getting involved. The other way is if you are a stakeholder organization, just please contact us and register for those April 24th and the future sessions. And it would be great to have you involved in the PA-PQC collaborative to help the PA-PQC sites make an impact on the goals. And another question that we've received is so what would happen if we as a team can't submit the aggregate data for all metrics in May? And I would say please don't let that deter you from joining the PA-PQC. We want to help identify what might be some of the challenges to reporting some of these measures, and we will work with you in a collaborative way to, over time, help you be able to report data on these required metrics. Data reporting as well as quality improvement is a journey, and this PA-PQC is meant to help support the quality improvement infrastructure that's needed to impact these goals. And as it relates to the data challenges, some of the measures do require claims data. As a provider organization, you could work with the health plans who are also participating in the PA-PQC to get feedback on the PA-PQC metrics that require claims data. And just to touch base on one last question, we are often asked if the PA-PQC teams are unsure of whether their team is able to complete all the quality improvement projects for all 3 foci of the PA-PQC by March 2020. Should they still join? And I would encourage you to still join the PA-PQC, and through the process of the PA-PQC, I think your team will learn from other teams, and those teams will learn from your team about how to do this work. And at this time, I'd like to give a very quick demonstration of how to access the various materials that we mentioned. So in terms of accessing the PA-PQC website, this is the website. You can download the presentation from the introductory webinar today by clicking this hyperlink. I noted that the PA-PQC's driver diagrams and quality measure definitions are now posted online. So for example, if you want to look at the driver diagram for opioid use disorders, you click the opioid use disorder tab, and at the very bottom it says resources, and that's where you can download the PA-PQC diagrams and the measures, and you can do that for the other 2 topics of the PA-PQC. And importantly, the Get Involved page is kind of your one-stop shop to register for the face-to-face sessions, beginning with the one in April 24, and also to join as a provider organization or to join as a health plan. And there's a Contact Us form at the very bottom. And just to conclude today's introductory session, our contact information for both the PA-PQC and the regional northeastern PA-PQC is displayed on this slide, including the different websites for the PA-PQC as well as the northeastern PA-PQC. And even though we are 2 minutes over, there is a new question that I'd just like to address, and the question is, their facility has less than 500 births per year, and we do not have a NICU. It does not seem like we fit the criteria to join. We are, as a collaborative, focusing on high volume delivery sites with NICUs initially. However, it is open to all delivery sites. So if you are from an organization that is very interested and committed to the goals of the PA-PQC and would like to join, please go ahead and submit those registration forms, and we will follow up with you. And that concludes today's introductory session, and I would like to thank everyone for taking the time out of your day to listen to the overview, and I hope that this session gave you and your teams more information and understanding of what the PA-PQC is about, and we look forward to working with you all as a PA-PQC site, and we are very excited to help launch and stand up the PA-PQC in the Commonwealth. Thank you, and have a great rest of the day.